learn about macular hole. Introduction. Macular hole is a full-thickness absence of the sensory retina in the macula. Idiopathic macular hole is the most common presentation. Risk factors include age, female gender, myopia, trauma, or ocular inflammation. Visual acuity is impaired, and metamorphosia and a central scotoma are present. Macular hole can be idiopathic or secondary to trauma or high myopia. Here are some pictures of macular hole. The first one is idiopathic macular hole, rarely causes retina detachment. The second one is secondary macular hole caused by trauma, usually combined with other eye disorders. The third one is secondary macular hole caused by high myopia. The risk of retina detachment is high. 4 stages of idiopathic macular hole. Macular hole results from tangential traction in the epiretinal vitreous cortex. Its development is divided into 4 stages. In stage 1, acute hole, there is a yellow spot at the fovea with loss of the foveal reflex. This stage is reversible if a posterior vitreous detachment occurs. In stage 2, there is enlargement with a deep peripheral yellow ring. In stage 3, the well-circumscribed full-thickness macular hole is surrounded by a cuff of subretinal fluid. In stage 4, the full-thickness hole is associated with a posterior vitreous detachment. Stage 1. Acute hole. Yellow spot at the fovea with loss of foveal reflex. Foveal detachment. Macular cyst. The vitreous body is transparent without detachment. Visual acuity is 0.3 to 0.8. Stage 2. Foveal full-thickness retinal hole. The size of macular hole is less than 400 mm. Most of the holes are eccentric in shape of half-moon, horseshoe, and ellipse. Stage 3. Foveal full-thickness retinal hole. The size of macular hole is more than 400 mm. Gray-white subretinal fluid ring can be seen around the hole. The vitreous body has not yet separated from the optic disc. Visual acuity is 0.05 to 0.3. Stage 4. Foveal full-thickness retinal hole. Complete posterior vitreous detachment. Visible with ring. Clinical manifestation. The visual acuity is significantly decreased, mostly below 0.5. Distortion from the Macular chart. The upper is normal and the lower is abnormal. Central scotoma. OCT examination is the gold standard for the diagnosis of macular hole, which shows the relationship between the posterior vitreous and macular hole, the size of the hole, and the pathological changes of the hole. Fundus examination shows the fovea is round or oval. The boundary is clear and there are yellow-white dots at the bottom. Visual field examination shows central or paracentric dark spots. More recently, the International Vitreomacular Traction Study group also formed a classification scheme of vitreomacular traction and macular holes based on OCT findings. Vitreomacular adhesion, no distortion of the foveal contour, size of attachment area between hyaloid and retina defined as focal if less than 1050 microns and broad if more than 1050 microns. Virtual macular traction, distortion of foveal counter present or intraretinal structure changes in the absence of a full-thickness macular hole. Size of attachment area between hyaloid and the retina defined as focal if less than 1050 microns and broad if more than 1050 microns. Full-thickness macular hole. Full-thickness defect from the interlimiting membrane to the retinal pigment epithelium. Diagnostic procedures. OCT is the gold standard in the diagnosis and management of this disorder. This high-resolution image can allow evaluation of the macula in the cross-section and 3D. OCT can be helpful detecting subtle macular holes as well as draining obvious ones. OCT can also help guide management. OCT can assist in the determination of whether there is an associated epiretinal membrane or if the posterior hyaloid is still attached or not, which can be critical in deciding on the surgical approach. It can also be used to aid in draining the It can also be used to aid in draining the prognosis of the yellow eye. FA demonstrates a hyperfrequency pattern consistent with a transmission defect due to loss of xanthophyll at base of the macular holes. This study is not usually necessary for diagnosis or management. Differential diagnosis. The clinical appearance of a macular hole is fairly distinctive. However, epiretinal membrane with a pseudohole, lamellar hole, and vitreal macular traction must also be considered. Cystoid macular edema, subfoveal drusen, central serous choroidal retinopathy, or adult vitreal macular dystrophy are also in the differential diagnosis of a stage 1 macular hole. Treatment. Stage 1. Observation. 50% of the holes can close without treatment. Stage 2. Operation as early as possible. The rate of hole closure was high and the visual acuity was improved obviously. Stage 3 and 4. Select the operation according to the patient's condition. Operation to reattach the retina of the cleft surroundings the macular hole involves vitreoectomy, separation of the posterior hyaloid, removal of the retina internal limiting membrane, and intravitreal injection of gas. Prognosis. The visual outcomes following pars plana vitreoectomy are very favorable. In general, better the pre-operative visual acuity results in better post-operative visual acuity. However, eyes with worse pre-operative visual acuity often experience the greatest absence post-operative improvement. A small number of macular holes can recur after a successful closure with initial surgery. Okay, that's all for this lesson. Thank you for your attention. See you next time.